Okay, we'll get started. We'll finish up. So this next lecture is on headaches and facial pain. They're not just going over like simple headaches. We're going to go through any cause that can give you a headache. As we go through this, so we're going to talk about H&Ps, acute headaches, your subarachnoids, epidural hematomas, those things. Your subacute headaches, things brought about by cancers and stuff like that. Then your chronic headaches, migraines, cluster headaches, and so on and so forth. So pain-sensitive structures of the cranium. Okay, the sagittal sinuses, meningeal arteries, very sensitive structures on the side. That's why that giant cell arteritis causes pain in the sides. Some parts of the carotid artery can cause pain. Dura at the base of the skull. Your trigeminal nerve, we talked about trigeminal neuralgia before, tic douloureux, that can cause facial pain and headache pain. Glossopharyngeal nerve, vagus nerve, brainstem, gray matter, and sensory nuclei of the thalamus. These are pain-sensitive structures within the cranium itself. Extracranial pain-sensitive structures, skin around the skull, neck muscles, second and third cranial nerves, eyes, ears, teeth, and sinus. If you have a tooth infection, will cause unilateral pain on the face. It doesn't mean that you're having a headache or a stroke, but obviously there's other reasons to have that type of pain. And oropharynx mucous membranes of the nasal cavity, if they get inflamed, they can cause some, again, sinusitis. If you ever had sinusitis, you know your face feels like it's being squeezed. That's facial pain, headache pain, but it's due to sinusitis. So classifying headaches, acute headache, new onset, demands prompt evaluation. So brand new headache. Headaches, especially in elderly, are not common if they've never really had them their entire life. So especially in the elderly population, any new onset headache, they've never really had headaches before, it requires some evaluation. You have to really start looking at scans and see what's going on with the brain itself and the skull. Subacute, over weeks to months, can, again, be serious in elderly or any patient with trauma. Bless you. And then your chronic ones occur over years. Most of them are due to benign causes when you've had these chronic headaches. So important things you gotta ask any patient coming in with headaches. Onset of time and timing. When did it start? How long have you been having them? What makes it worse? What makes it better, like you normally do? But you want to ask questions related to the headache. Do you go into a quiet room and that makes it better? Is it worse with coughing? That indicates some increased intracranial pressure with the coughing. Worse upon awakening. The quality. Okay, again, that worst headache of my life. Okay, your subarachnoid hemorrhage. Watch out for that. Is it different than my usual headache? Always try and compare to their last headaches. Is this the same time you get it? Yes. Those who had migraines, is it the same every single time you get it for the most part? The same every time. Now, Gabby, I'll give you a break. When you had your migraines, if it was something new, obviously then we have to be worried. But when it's the same thing every time, what kind of symptoms do you get every time?
Unilateral eye pain that shoots through that problem.
Any tearing?
No.
No, what about,
So
we're going to go through the mnemonic in a little bit, but she has the same every time. Do you have an aura before it comes on, or just sometimes? Okay. But again, if it was something new when she had a headache, now she's having like numbness somewhere or tingling, some paresthesias, that requires a more thorough workup. But if she comes in, back to the emergency room and like, I'm getting a migraine again, this is the medicine that works well for me, they'll know, give them the medicine and they feel better, then you send them home. That's a routine migraine. They come every time, the same symptoms. Also describe the type of headache. Is it a throbbing pain? It gets worse, then it gets better, worse, then it gets better, throbbing, pulsating, very similar, lancinating, that knife-like is like someone's putting an ice pick into my head, so forth. The region, what part of the head is being affected? Is it just behind one eye? Is it unilateral, just one half of the head is having a headache? Is it band-like, where someone's like wrapping a towel around your entire head and pulling? That is band-like. Occipital is pain in the back of the head. Occipital headaches are usually due to high blood pressure. When they have very high blood pressure, they usually get pain in the back of the head, and that's check their blood pressure, it could be high. Severity, how does this rank to your other headaches? Is this the worst one you've ever had, about the same, or and so forth? So important things to consider when you're doing a headache H&P. Other factors, again, I'll put both up. Fever, chills, think of infection. They're having a lot of weight loss, rapid weight loss, and they're not wanting to lose weight, but they keep losing it. Possible cancer, inflammatory problems. Photo or phonophobia, think migraines, meningitis, subarachnoid. If they have any myalgias along with it, tension headache, viral syndrome. Neck stiffness, again, there's your meningitis and your subarachnoids again. Other concerning factors, trauma. Always ask about loss of consciousness with any neuro patient. Did you ever pass out from this? What happened beforehand and so forth. And then worst headache and also a recent lumbar puncture. So we've talked about lumbar punctures. One of the side effects, they can get really bad, severe headaches afterwards. Usually have to do what's called a blood patch, where you kind of like fix the hole and they feel better after that. Visual changes with a headache. Think of an ocular disorder, migraine, intracranial processes that are affecting those pathways. The nerves that are involved, they're all within the brain. Nausea and vomiting, common with migraines. Post-traumatic headache syndromes, like your concussion. Okay, they'll have some nausea and vomiting after concussions. Again, they're going to have headache. It's going to hurt because they just had a concussion. Ipsilateral rhinorrhea and lacrimation, that's usually cluster headaches. Okay, so tearing and runny nose on the same side. So the right eye is tearing, the right nose is snot dripping out of it. That's the same side. Transient loss of consciousness, migraines, and some glossopharyngeal neuralgia as well can cause that. Physical exam, vital signs, skin. Make sure you palpate the scalp, face, and head. Okay, look for those sensitive cranial structures and see, does it hurt? Make sure you ask the patient as well. Always ask before anything that has to elicit tenderness. Ask the patient, let me know if anything hurts when I do this. Okay, I've seen you guys on OSCEs just go through a whole exam and say no tenderness, but you never ask the patient if they had tenderness. You have to ask the patient. They tell you if it hurts or not. Neck exam, your neuro exam as well. So that's kind of like your history and physical, what you want to do for any type of headache patient coming in. So causes of acute headache. These are the, obviously the ones you want to avoid. These are all the killers. If you miss these ones, potentially your patient can die from these. With a subarachnoid hemorrhage, trauma is the most common cause. So ask your patient what happened before this, were you in an accident within the last week or two, what happened? It could also be due to a ruptured cerebral arterial saccular berry aneurysm. So we talked about aneurysms before. So we have our one side and we have an outcropping. And it looks like a bunch of berries, like grapes, little bumps everywhere. Those can break very easily. They call them berry aneurysms, and if they break, guess what? Now you have a hemorrhage. Because you have an open vessel that's bleeding blood into a cavity. In this case, arterial saccular is a subarachnoid hemorrhage. Less often from those AVMs, the arterial venous malformations, where you have your arterial side, and then you have your, I'll do it blue, your venous side, and they connect in the middle. That is an AVM, arterial venous malformation. Those are not normal. You have a communicating vessel between the arterial and venous blood. And that little area right there is also very weak, and it can burst very easily. But with subarachnoid, that's usually due to these aneurysms, not an AVM. Bleeding, increased intracranial pressure, because now there's blood going into these cavities that it shouldn't be, increasing the swelling of the brain, increased intracranial pressure, now you have your headaches. Increased intracranial pressure leads to decreased cerebral blood flow. And if you have less blood flow going to the brain, your body's mechanism to prevent that is to just collapse so that you fall on the ground. You don't got to worry about gravity anymore because blood will just flow to the brain and hopefully get better. So they're going to have loss of consciousness with that. Cardinal symptoms, again, worst headache of my life. 50% will have a sentinel bleed somewhere in their brain causing all this. Loss of consciousness, sudden onset is also called a thunderclap headache. It just comes on full force. There was no ramping up of the pain. It was like, here we are, and now we have all this pain in the head. Photophobia, nausea, vomiting, neck stiffness. Non-focal neuro exam. You're not going to see any paresthesias, weakness, sensory issues in the extremities. Those are focal neurologic signs. They're not going to have those things with a subarachnoid hemorrhage. Diagnostic studies. Number one, always head CT without contrast. Okay, you're looking for a bleed. You don't want to put contrast dye into the whole body. So no contrast at first. Very accurate first day of bleed. They can show some high attenuation consistent with bleeding. Also use contrast if you think they have an AVM. Follow up with MRI. If they're stable, get an angiography of the brain. See what's doing up there. If the CT is negative, doesn't show any bleeding in the subarachnoid space, but your clinical suspicion is high for a subarachnoid hemorrhage, get a lumbar puncture. Okay? Increase intracranial pressure because there's blood in that space plus CSF. You're adding too much volume, so the opening pressure is going to be high because of all the fluid that's there. It's going to be bloody. It's called xanthochromia. When you break down hemoglobin, it gives that supernatant in a yellowish color from the red blood cells being burst. And that is what you're looking for, signs of bleeding in the subarachnoid space. Treatment. Keep elevated arterial pressure. Don't go lower than 140/100. Okay, they need that pressure to keep everything else perfused. Okay, prevent elevated intracranial pressure. Strict bed rest with head elevated, may need sedation depending on how severe, so that medically induced coma to let everything kind of relax. IV fluids, normal saline only if needed, analgesics as needed, don't give aspirin. Okay, they're bleeding, you want to give aspirin. And then surgery, we talked about clipping and coils before, how to repair these aneurysms, and either they'll ligate or embolize it, and then this needs to be done by a neurosurgeon. And they're the ones who will go in, they'll fix all these things. Prognosis. If they have vasospasms with seizures and an elevated intracranial pressure, they have a worse prognosis. They're getting some brain shifting going on, some mass effect, causing these seizures to occur. You want to prevent cerebral vasospasm with nimodipine. What kind of drug is that? Calcium channel blockers. Okay, going to keep those vessels dilated. And we don't want them having vasospasm because that can cause a stroke-like issue. Rebleeding. 20% will die from rebleeding. So the aneurysm stops, but then it starts bleeding again and then get issues. Very high mortality rate. Almost half these patients will die within the first 3 months after having a subarachnoid hemorrhage. So we kind of do everything we can, look at the prognosis, the age of the patient, what other symptoms are they having? Is they having seizures? That's a bad prognosis. That means we're having some mass effect compression of the tissues of the brain. Meningitis, we talked about a little bit before. Infection of the brain or the meningeal coverings, can be viral, bacterial, or other. Which one's better to have of the two? Viral. Headache, obviously, is going to be a prominent feature of meningitis. They're going to have a headache. And worse when sitting upright is one of the clues, because the other ones, we know they have nuchal rigidity, we know we're going to have throbbing, and obviously pain due to inflammation, intracranial pressure going up. Those sensitive structures we talked about in the beginning of the class are now starting to get affected, and you get headache pain. Photophobia, mental status changes with meningitis as well. Subdural hematoma. Okay, so what layers are these between? Subdural. Yeah, right, arachnoid, yeah. I'll think of the lower one. You're right. So this is bleed occurs within the skull, but outside actual brain tissue, because we have 2 more layers to get through the arachnoid and the pia. This is between the dura and the arachnoid. Most commonly is going to be a vein with these ones, with these subdurals. With the subarachnoid, it's an arterial break. With a subdural hematoma, it's a venous break. We have a break in the venous supply. Blood leaks out of the torn vessel and in the space between the and below the dura mater, also known as a subdural hemorrhage, intracranial hematoma, or this is where your traumatic brain injuries occur in this level as well. Okay, so this is a venous tear. Now, what side, venous or arterial, is under more pressure? Arterial. So these are venous sides, so it's going to be oozing out. And because it's oozing out, you're going to see how the presentation is different because it's a slower, gradual issue with a subdural hematoma compared to a subarachnoid. It's thunderclap, immediate headache, because the arterial system is just pushing all that blood into the ventricular space, causing all the issues. Subdural hematoma, we're not even at the brains, we're still in the coverings, and it's usually a vein. 25% of people with head injuries. This usually happens in elderly people when they're in like car accidents or where they fall. Because whenever you stop suddenly, your skull and the brain move separately. The brain kind of floats. It's packed in there, but it's still free moving essentially. That's why when you get like a headache or a concussion, what really is happening, the brain is hitting the skull, and that causes the bruise, is the brain hitting the back of the skull. So in these cases, usually elderly people, they get like the veins, the bridging veins, they, due to shear forces of, you have your brain, and then, I'll put it in blue, but it's all venous. Okay, when you have a stop suddenly, like a car accident, it goes forward like this, those things get cut and sheared off essentially, and that causes the bleeding to occur because their veins, they're weak, but that's what's happening. Those shear forces make them rupture. Now, at first the bleed is slow, so they're not going to present with a lot of symptoms because again, this is venous supply. It oozes out. It's a very slow drip of the bleeding. So at first the body can handle that excess blood and try and get rid of it, but it's going to constantly keep leaking because you never repaired the veins and they keep going. If the hematoma is severe enough, buildup can cause pressure on the brain, breathing problems, paralysis, again if the brain stem has been affected now with the subdural hematoma. So types of subdurals, the acute is the most dangerous one. Symptoms appear right after the head injury, but you're going to see later on, usually those symptoms will get better and then they get worse. And when they get worse and they come back, then they crash on you. And these ones are going to complain of headaches and everything right afterwards, but then it's going to get better and go away because now the body has kind of caught up to the healing process to get rid of that excess blood, so you do feel a little bit better. That's called a lucid period, where they actually will feel better, but then they crash like 5 hours later. So if not recognized early, patient can deteriorate quickly, leading to loss of consciousness, paralyzation, or even death. Subacute symptoms appear after hours or days. That's like your concussion. Some people do have chronic subdural hematomas. There's such minor little breaks that the doctors don't even worry about going to repair it. Very subtle changes in those people, but common in elderly. So risk for subdural hematomas, again, older adults, we talked about those, as the brain shrinks, the cortical atrophy, those veins kind of get pulled as well. They get pulled tight because the brain is pulling away from the skull because of atrophy. So those veins get pulled taut and they can break easily. Contact sports, blood thinners, hemophiliacs, alcohol abuse, and babies are at risk for subdural hematomas. Symptoms may develop immediately over weeks to months. You have headaches that don't go away, some confusion, nausea, vomiting, slurred speech, dizziness, weakness on one side of the body. In some cases, they have no symptoms immediately after, okay, but then they develop days later, okay? They're going to decompensate fast. So anyone coming in with a trauma to the head, motor vehicle accident, unrestrained trauma to the head, and they have risk factors for, they're elderly, scans don't really show anything, make sure you let the patients know when they go home, let family members watch them. If they start crashing, you gotta bring them into the emergency room right away, or you just keep them in there for a day or two and watch from there. Diagnosis, complete history. Again, finding out was there any trauma with that patient. Full neuro exam, and again, CT, no contrast at first. See, you don't want to have that tainted blood leaking everywhere. Treatment, if they have a large hematoma, surgical decompression. This is the things that you see where the neurosurgeons have the drill, and they drill a hole in the skull, and they see the hematoma right there, and they just suck it out. Remember, this is not in the brain, it's right between the dura and the arachnoid layer. So all you need to do is remove the dural layer, pull all that blood out, then you sew the dural layer back up again, and you close them up again. So that is it for large hematomas. These are those bore holes that they drill into the head. May need repeat surgery if they still have some remaining blood clots to get all those things out. For small hematomas, just bed rest, observation, watch and wait. See what symptoms they are. You'll repeat a scan in probably a month. Then if that's okay, then you may go to wait 3 months and check it again. If that's okay, you can wait 6 months for the next one. But you want to watch this thing and make sure that the size isn't getting any worse. Complications of subdural, brain herniation, bleeds, and seizures, depending on that brain mass effect from that increased blood in that area that shouldn't be there, compressing your brain tissue that can potentially cause seizures to occur. So those are the acute forms of headache. Now we'll talk about the subacute ones. Brain tumor, this is why any new onset headache in an elderly patient, you gotta scan them because the risk of brain tumor goes up when they have a new onset headaches. Tumor growth causes the symptoms over several weeks to months. Again, you gotta wait for that tumor to get enough size to where it starts compressing the tissue around it. That causes the headache. Headache is worse in the morning or with exertion or Valsalva. Also should arise for brain tumors. Other suspicious criteria, cluster headaches, abnormal neuro, undefined headache symptoms, or headache with an aura as well. And again, as I keep saying a lot, new onset headache later in life should raise suspicion for tumors. Because none of you guys can get this one either, I don't think. Old movie, but. Okay, physical exam may be non-focal, papilledema. Don't do LPs on people with brain tumors. You get that brain herniation. The brain gets sucked into that foramen magnum. Diagnosis, contrast, CT or MRI. You got it because that will tell you, now you're not looking for any bleeds, you're looking for tumors. And if they have a blood supply, blood will go into there with the markers and you'll see a glow as well. Biopsy to confirm what kind of cancer it is so you know what to treat. Giant cell arteritis, temporal arteritis, external carotid artery at the superficial temporal artery. Mean age is 70, more females than males get it. Signs and symptoms, pain over scalp at the temporal artery, jaw pain or stiffness when they chew. And again, you got to treat it as fast as possible to prevent blindness. And the treatment is your steroids. Urgently with prednisone to avoid vision loss. So burst with slow taper over several months. You can't just give them a week of prednisone with this one. You got to leave it on for a while. Make sure that swelling goes down. So you check your SED rates and all that fun stuff for inflammation. Idiopathic intracranial hypertension. This is also known as that pseudotumor cerebri. Often idiopathic. We don't know why it starts. Can also be seen with certain drugs during steroid removal or withdrawal and venous sinus thrombosis. Classically, middle-aged obese females, and usually are typically limited to a few months of this idiopathic intracranial hypertension, then it goes away. What kind of symptoms they're going to be having? Generalized headache that's worse with straining. So whenever you bear down or strain, the intracranial pressure also goes up, and if you already have it elevated and it goes up a little bit more, it's going to cause the headaches to be worse. Nausea, pulsatile tinnitus, you'll see with them as well. Some vision problems, papilledema is here as well. Get an MRI to rule out a mass. That's why it's called a pseudotumor. It's not a real tumor, but it presents like you do have a tumor in the brain. Increased intracranial pressure, all these other issues, but nothing else is going on. Elevated CSF pressure. Because then they have too much CSF is basically what's going on. There's too much CSF fluid, and that's what's caused them to have all these headaches and whatnot. So the treatment is LP drainage. Yes?
Wouldn't that cause the herniation of the brain?
Not in this case because they just have ventricles are swollen a little bit. They don't even be swollen that much, but just too much fluid. So you just pull it off. You can also give some diuretics, acetazolamide, furosemide will work as well. Another thing they can do, they'll put an actual, no, it's not. It's I think it's EVD shunt. It's like endovascular drainage. Basically, they put a tube from the ventricles in the brain, usually the back of the neck, and it drains into the peritoneal space. So all this excess CSF just gets dumped into your peritoneal space, and your body reabsorbs it. And that helps with the headaches by removing the CSF. Post-herpetic neuralgia will also, again, present with headache or facial pain. Varicella for your shingles, and usually that first distribution of cranial nerve 5. Deep gnawing pain, sharp elements exacerbated by contact. So, again, trigeminal, cranial nerve 5. Yeah, trigeminal. Corneal sensations, blink reflex. Again, the distribution of the trigeminal nerve, you may have problems wherever they innervate. Exam, decreased pinprick sensation, so sensory is diminished as well. Treatment, here are your amitriptyline, gabapentin are the first line. Again, this is neuropathic pain. You can try opioids because the pain is going to be really bad with these patients, but there's a dependence with opioids. You want to get them hooked on these things, so try the neuropathic stuff first. Usually subsides 6 to 12 months. They may go on, but again, also if it's acute shingles, you give your steroids and acyclovir as well. Okay, same thing with any type of viral, HSV, VZV, acyclovir or prednisone are your two mainstays of treatments for those ones. Good question? Okay. Your trigeminal neuralgia, we went through compression of cranial nerve 5, lancinating pain, and treatment spontaneous, and there's your treatment carbamazepine, baclofen, those neuropathic pains. So last thing we'll do now is talk about your chronic headaches. These are the ones that people are going to get normally. They're going to come in complaining of all the time, and we'll go through all these different ones as we go. So determine the similarity to previous headaches, like I did with Gabby. Is it the same that you've had before? Are they always the same? If they change, then you gotta be worried. And immediate evaluation if off. Migraines. What causes migraines? There's a few different theories. One of them, increased serotonin from intracranial vasoconstriction. Vasoconstriction, this is what causes the orophase, and that results in hypoxia. So that's the orophase that sometimes people will get beforehand. Then they get a rebound vasodilation during the headache phase. You get a drop in serotonin levels. So vasodilation is what actually causes the headaches to happen with these normal recurrent headaches that people just get normally. It's vasodilation. It can be precipitated by certain foods. Chocolates and cheeses are the most common. So people get recurrent headaches, do a headache diary, see what they were eating beforehand. In women, find out, is it cyclical with their period? That can also cause headaches to occur as well. So you have to figure these out with these headache journals. Migraines, more females than males. 15% of women will have a migraine at some point. There is familial clustering, so if anyone in the family has history of migraines, there may be a chance that you will have migraines as well. Common onset between 20 and 30. That's why I said elderly people, 60, 70 and above, start getting headaches. That's not normal. Check them out for a brain tumor or something else. 90% before age 40 of migraines. That's why anything over that, new onset headache, watch out. Okay, so here's the pound mnemonic for migraines. 4 out of 5 positives, 92% probability of a migraine. The P is pulsatile. Is the pain, is it pulsatile? Is it pulse, or is it just constant? The O, the onset duration between 4 and 72 hours. So it's a rapid onset within a day or two. Unilateral in location is the U, one side or the other. N, nausea and vomiting. And finally, the last one is disabling, D. The headache is severe, you can't do your normal activities of daily living. You just want to cocoon up and live in a dark room, no one talk to you, and a few hours later you'll be better. So again, disabling, rapid onset, so on and so forth. So that's the pound mnemonic for migraines. You need 4 out of 5 for a normal diagnosis of migraines. So often occur monthly. They're going to have photophobia, scomatas are there. Migraine without an aura is called a common migraine. They have no preceding aura. If they have a migraine with an aura, it's classic or a complicated migraine. So on a test, if I say the patient had an aura beforehand, they had an aura, it's a classic migraine. If they did not have an aura, it's a common migraine. Okay? Exams and studies, everything's going to be normal outside the attack. So when they're not having a migraine, everything's fine. When they have the migraine, then they have the photophobia, all that fun stuff. They will appear very ill during the attack, but no focal neurologic signs. Everything's going to be fine. No paresthesias anywhere, no weakness anywhere. Imaging, again, not necessary unless they have new symptoms. If Gabby came in and now she's saying, my right hand feels numb now, that's a new symptom than what she normally had. Let's get a scan, make sure the brain's okay. Otherwise, they come in, this is how I normally am. Just give me some Phenergan, Benadryl, I'll be fine. Okay, watch you, and then you go home. Don't go crazy because they have migraines. Treatment. These are abortive symptomatic treatments. When you're having a migraine is when you give these things. Simple analgesics, acetaminophen, NSAIDs, your ketorolac, Toradol is very good. Aspirin with caffeine. Okay, caffeine is a vasodilator. So that's why it helps with headaches, because it's going to constrict the vessels in the brain, therefore lessening the headache. Fiorinol, Fioricet are like big combo drugs. They have a bunch of different things in it, but it's usually just for headaches for those. Your 5-HT agonists. Now we're dealing with serotonin stuff. We talk about how serotonin is high, causes the vasoconstriction, that aura phase. Then serotonin drops, you get vasodilation, now you're in the full headache phase. So we give 5-HT agonists. Sumatriptan is the big one. Different forms, subcutaneous, nasal spray, PO. Works best if you start it early on. Sometimes people have the little pens in their purses or whatever. If they know they get migraines, they can use the pen, get it going first. Causes vasoconstriction of the carotid arterial tree. So they're going to get some flushing, some tightness in the chest as a side effect. Doesn't mean they're having a heart attack, but a side effect of it is. But because of that, contraindications, cardiac disease, and pregnancy. You can't give these 5-HT agonists to a pregnant patient or if they already have underlying cardiac disease. Treatment, these are ergot preparations. Okay, ergot is a part of the mushroom family. So Caffergot is just ergotamine with caffeine in it. There's different types. Again, it works best if early on. The contraindications are the same. Cardiac disease, pregnancy, don't give them these types of drugs. Antiemetic. Okay, you gotta treat not just the condition they're having, but the side effects. Nausea and vomiting is part of it. So you can give Reglan, you can give Compazine. Those are good for antiemetics. Okay, what's not on this list? Zofran. Okay, you don't want to give Zofran so much all the time. Try these other ones first. And be careful with narcotics because of dependency to the narcotic. They don't really need it. So those are ways to stop the migraine. Now, people who have recurrent migraines, they can go on prophylaxis for their headaches. Frequent attacks, usually more than 1 week. You can give beta blockers like propranolol. Low dose propranolol will help with migraines. Again, these are to abort them from even starting. TCAs can do it, valproic acid, topiramate. And then again, avoid the triggers. Find out what their triggers are. Red wine, cheese, all the fun stuff. Chocolate, okay? You know what your triggers are? Alcohol, okay, so easy one. Is it all alcohol or just wine? Most alcohol, okay. So obviously, if she knows she's gonna drink, she's gonna have a headache afterwards. So. Drug rebound headache. Okay, so how many of you started drinking caffeine like crazy here, and then you go home for break and you don't drink any? What happens when you go home and you didn't drink any caffeine? You get a headache. Okay, that's just drug withdrawal from the caffeine. So another cause of a headache, increasing amounts for relief, then when the headaches drop, or when the levels drop, the headache starts. So again, find out what changed in their diet. Were they drinking a lot of coffee and then they stopped? So either they get over the withdrawal symptoms or just drink some coffee and it goes away. Treatment, again, abrupt withdrawal of the meds containing sources. You can try sumatriptan or those ergotamines during the transition. While they're getting like the rebound withdrawals, while they're going on still, you can give sumatriptan or just some Tylenol, stuff like that. Once the withdrawals go away, the headaches will stop. Cluster headaches is the next one. So cluster headaches is a unilateral headache. Okay, it may start as a burning sensation over like the eye or the nose, and then the headache kind of flares up from there. Usually occur at night, and they may awaken you from sleep. Not many headaches will waken you up. Cluster headaches can wake you up. Lacrimation and tearing on the same side as the headache. We also learned about Horner syndrome before, and they also have tearing and lacrimation on the same side. So what's the third part of Horner's that you want to look for? Not so much ptosis, what else? Sweating. They're going to lose sweating on the side of the lesion. So cluster headache starts as a cluster of brief, severe, constant, non-throbbing attacks that may remit for months at a time. They may last a few seconds. They may last up to a couple weeks. So cluster headache, unilateral. They're going to have tearing, lacrimation on one side of the head, the same side that the headache is on. Cluster headaches are more common in males. It's one of the only ones that's more common in males. Rarely associated with any family history with cluster headaches. Begin around age 25, and maybe due to activation in the hypothalamus. There's some different theories about why cluster headaches form, but don't worry about that for the exam. There's theories. So treatment, the biggest one is 100% oxygen. That will knock out the cluster headache. Just 100% O2, have them breathe it for a little bit, it goes away. You could try other ones, sumatriptan, lidocaine, your ergots as well for the pain relief, but with cluster headaches, 100% O2 is the best thing you can just give them. Prednisone may stop the cluster attacks, so if you have multiple at a time, they may help. Prophylaxis options, here's your calcium channel blocker again. If they get recurrent cluster headaches that are debilitating, they're affecting their life, affecting their ADLs, they can't go to work when they have it, that's recurrent, it's too much, then you go on these prophylaxis ones. Verapamil, topiramate, are the two big ones. The other ones are still equivocal as far as their efficacy. So here's a cheat sheet for you guys for your cluster headaches. Tension headaches. It's chronic headaches, unapparent cause that lack features of migraines or clusters. So they're kind of like the catch-all at the end, these tension headaches. The underlying pathophysiology is unknown. Part of it thinks the contraction of neck and scalp muscles can make this thing worse. Typically occur after age 20, begin before age 10 in about 15% of these patients though. 4% have chronic tension headaches. Episodic effect up to 80%, more females than males for these tension headaches. Band-like is the big one here. This is like the towel wrapped around their head and it squeezes. That's a tension headache. They can last 30 minutes up to a week. Chronic tension headaches can last hours and may be continuous. Be more than 15 days per month for at least 3 months. Typically bilateral, forehead, temples, and occipit. So again, bilateral. Clusters and migraines are unilateral headaches. Tensions are bilateral headaches, whole head. No photophobia, nausea, vomiting, or vision problems with this tension headache. So they're not having any issues there. The exam is normal between attacks. Normal exam on fundoscopy. No studies are needed if the history is typical. You meet the age criteria, female, tension headaches, they come on, once in a while. So for tension headaches treatment, just simple analgesics, that's all you need. NSAIDs, ibuprofen, naproxen, Tylenol. These ones are you have to give in the hospital. You can't just prescribe those things. But obviously Tylenol, Motrin, those things work just fine. Avoid a rebound headache. Prophylaxis, your TCAs. SSRIs do not appear to be helpful because we're not having an issue with serotonin. Okay, nothing to do with that. Cognitive behavioral therapy, okay, lifestyle modification, exercise is good. Reassure the patient the syndrome is real and treatable. Okay, reassuring of the patient is very important. Okay, let them know that yes, you may get these frequently, but they're not bad. They're not, it's treatable. We can give medicine for it, and stuff like that. Kind of just reassure them that it's going to be okay. Here's tension headaches versus migraines. Tensions are non-throbbing. Duration is hours to days. Location, band-like is the big one, or mainly the back of the head. There's no prodrome, no nausea and vomiting, may or may not have photophobia, and not a strong genetic history for tension headaches. For migraines, it's a throbbing, hours, it lasts, unilateral, they're going to have an aura, nausea and vomiting is there, photophobia is there, family history is there, so forth. So these are the difference between a tension headache versus a migraine headache. Post-traumatic headache, obviously following a head injury. Okay, so they hit their head and now they have a headache afterwards. The symptoms don't necessarily correlate with the severity of the injury. So don't just, they're not really having a bad headache right now. No, so treat them as if they were, rule everything out. And this is why you need to rule out that subdural hematoma. What did I say about those subdurals? How are they going to present sometimes? Normal. They're going to be fine. And then 4 hours later, they crash. Well, they may present like a post-traumatic headache. They were in a car accident. But if you don't know they have a subdural hematoma, they can crash 4 hours later, and then they have a loss of consciousness, and now they go to the ICU. So that's why I'm saying don't forget about these subdural hematomas with these patients with this post-traumatic headache. Find out the mechanism of the injury, what happened. What part of their head did they hit, whether it's steering wheel, windshield, whatever. So headache usually within 24 hours of injury, constant dull ache, worse with head movement. Okay, as you're moving your head, those structures, those pain-sensitive structures are now being moved, whether it's muscle pulling or whatever, but as you move your head, it makes the headache worse. May worsen over a few weeks with gradual improvement. Nausea and vomiting is common. Exam is non-contributory. CT, MRI are normal. So this is your concussions as well. Your post-traumatic injury, you hit your head, severe enough, they'll have these post-traumatic headaches for a while. Treatment, simple analgesics again, Tylenol, Motrin, Advil. If the pain is really bad and is refractory to analgesics, you give amitriptyline, propranolol. That will help with the headaches as well. Encouragement again, patient reassurance. They're going to get scared because they have these recurring headaches. Not sure what's going on. Reassure them it's okay. It's part of the healing process from the traumatic injury. It'll get better over time. Non-neurologic diseases that can present with headaches. Sinusitis obviously is a big one. You'll be doing all the tapping and it elicits a lot of pain when you tap over the sinuses because you have sinusitis, inflammation that causes headache and facial pain. Dental, TMJ dysfunction, tooth abscesses. Okay, also going to have pain in the face with those issues as well. Glaucoma can present, depression can also present, similarly with headaches, chronic headaches, and so forth. So there's your summary of concerns for chronic headaches. Any type of new neurologic findings, watch out for those. If the headache is worse with Valsalva, requires additional workup with those patients. If it wakes them up from sleep, as a concern, usually only clusters do that. New headache in older patient. Okay, brain tumors, headache for progressively worsening or the progressively worsening headaches. Exertion induced, they get seizures with it. Worst headache ever, your subarachnoid hemorrhage. Family history of aneurysms. Now your risk for these subarachnoid hemorrhages go up. And obviously your clinical judgment regarding individual patients. All should have an MRI CT at some point in their life, and that's your benchmark. You want to see if they have new onset symptoms, compare your new MRI to the old one, see if there's any changes that would be reasoning for having this increased headache. Imaging, again, if they're here repeatedly, they have the same symptoms, you don't need to do anything. If symptoms have changed, then you need to start worrying about imaging. And obviously, any of these symptoms warrants imaging to work up. Again, not necessary for patients with classic migraine and normal neural exam. Tension type headaches and normal exam, don't worry about doing any imaging for those patients. MRI is greater than CT, but obviously CTs, it can get done a lot faster. And here's some websites you guys can go to with different types of headaches. And we are done with headache and facial pain. So on Friday, we're going to do movement disorders and disorders of consciousness. And then we'll finish up neuro on Friday.
Thank you so much.